Okay, great. I think we're live. So we are. I've got a button in front of me that now says we're live. So welcome everybody to the first ever virtual meeting of the All-Party Parliamentary Group on Mental Health. We've got a virtual session this evening using Microsoft Teams. So apologies firstly if we can't see and hear everybody on the call. You should be able to see all the presenters, but you'll only be able to hear and see the presenters. However, everyone can send questions via the Q&A link, and then I'll be putting the questions to our presenters when they feed through. Firstly, thank you to our Secretariat from the Royal College of Psychiatry for making this happen. And I'm relying on them to jog me when I get things wrong and make a mistake, because this is my first time hosting on Microsoft Teams. So fingers crossed, everybody, that it goes okay. But they've done a great job putting this together, so we're very grateful for that. Why we're here? We're really here to consider and discuss the impact of COVID-19 on mental health and mental health services. Some of the things we might want to consider. We've obviously had a number of temporary legislative changes to the Mental Health Act, to the Care Act, changes to requirements and provisions for welfare benefits that are meant to make the system more flexible and to help people, but may make it trickier to use perhaps for people with mental health issues. So those are some of the things we might want to consider. But I think really the most important thing is we want to talk about the effect of the virus, the effect of the lockdown on the mental health of the wider population, but in particular maybe on those people who are risking their own safety by going to work as key workers in the crisis, particularly if they're in health and care settings, and thinking about how this whole crisis might affect them, but also affecting the wider population and the fear of the disease, the effect of lockdown, and the very strange times that we're living in. And the other thing that we might want to think about is the implications for services. So the implications, particularly for demand on services and the kinds of support, particularly maybe it's new kinds of support that people might need. So we've got until 6:30 to.
I can't hear now, it's Mary here.
Your mic's off, Jonathan.
Sorry, this is Jonathan from RCPsych. We seem to have lost Jeff Smith there for a second, and I forgot to put my microphone on to tell you that. I just can't see if Jeff, are you there? Can you hear us all on this one? No, I don't think so. So sorry about that. So maybe if we go into our first speaker while we're waiting for Jeff to come back on, and that is Danielle from Rethink. So if I just get Danielle coming up, see if this works. Okay, Danielle, you ready to go?
Thank you. Hello everyone, and thank you very much for logging on today. So I'm going to focus my talk on the interim findings from a survey we're running on the lived experience of people with existing mental health problems during the pandemic. But first I'm going to say a brief word about Rethink Mental Illness, which was founded as the National Schizophrenia Fellowship 50 years ago. Today we support people with a far range of mental health conditions, but we have kept true to our roots in supporting people most severely affected by mental illness. We provide direct services, including advocacy, supported housing, crisis and employment services, as well as campaigning for change on a systemic level. I lead our influencing agenda, and we see one of our main roles during the crisis as helping policymakers and the wider public understand the impact of the pandemic on those living with mental health difficulties. So I mentioned the survey is still open. Currently, we've had around 2,000 people respond to it, and I'm going to talk about a snapshot of the data taken last week of around 800 people with mental illness. Of these, 8% were in inpatient care. That means they were in hospital or detained under the Mental Health Act. 50% were under a care team in their community, and the rest were receiving services within primary care, many receiving IAPT, for example. That's talking therapies. So please bear in mind that this is just a top-level snapshot that I'm going to be giving you today. We have several hundred qualitative responses that have not yet been fully analysed. However, what I can do is give you a flavour of the early findings and the quantitative data. So it will be no surprise to most of us that the pandemic is having an effect on mental health, but we were still shocked that 80% said coronavirus, and the measures taken to contain it have made their mental health worse or much worse. It's worth highlighting again that this is a group of people with existing, often severe mental health problems, as opposed to people who have developed symptoms as a result of the pandemic. We're talking about a group of people that have been chronically underserved by the system, suffering from decades of stigma and underfunding of services. Things were just beginning to change for this group with the introduction of the NHS long-term plan that focused on the needs of people with severe mental illness. But now the pandemic threatens to set back the clock. The most common reasons that people gave for their mental health getting worse included not being able to do normal activities, not being able to see family or friends, or worrying that loved ones would catch the virus. Now, these will be difficulties that we can all relate to, yet the impact will be very different for somebody who's already experiencing severe mental illness. For some, regular visits from friends and family, the ability to exercise or access outdoor space can be the difference between staying well and becoming seriously unwell. The way that people are affected by the changes to daily life also depends on their condition and their circumstances. Some people with eating disorders, for example, are struggling to find the safe foods they need. And sadly, we heard from more than one respondent that they had been in recovery from anorexia and now had relapsed. Those with compulsive behaviours told us that they find the constant public health messaging and the genuine existential threat that it represents is making their symptoms worse. One person who had been well for years told us that their PTSD had returned, saying, "I'm experiencing flashing terror and I haven't any tools to talk to a terror that is not, in fact, in any way irrational or disproportionate." And it can be terrifying for someone who has paranoid delusions to be visited by a healthcare professional in full PPE. One strong theme to emerge from the survey is the extent to which the changes to mental health services are affecting those who are normally supported by them. 58% say that support has become worse or much worse since the UK was affected by coronavirus, and 47% say that their mental health has become worse because they are now receiving less support than they used to. And as we well know, even before the crisis hit, many people with severe mental illness were not getting the support they needed. A concerning emerging theme was that some services had just been completely withdrawn. One person told us, "I feel on my own with no support," when I had just managed to access that support after 2 years of fighting for it. The survey demonstrated that whilst people well understand why services have had to move online, for example, it doesn't change the fact that many people find online appointments less helpful, and some find them impossible to engage with at all. And it's not just clinical appointments that are affected. Community services such as peer support groups and crisis cafes have stopped meeting, either in person and often virtually. Many of those who are entitled to social care because of their mental illness are also finding that their visits are being replaced by phone calls, or that they're not getting those visits at all. We hear from our own services that many Care Act assessments simply aren't happening. And we have already heard from our services of instances of people being detained under the Mental Health Act as a result of their mental health problems escalating due to a lack of preventative support. You don't need to be a specialist to understand how important face-to-face contact can be in mental health care, and we have real concerns that those patients who really do need to be seeing their psychiatrist or nurse face-to-face might be missed. One person told us that they had not received face-to-face contact despite having been ventilated for 5 days this March before being able to breathe again due to an overdose. I live alone, they told us, and have no support network, and just phone contact has not been enough. Our survey also highlights worrying trends that suggest that physical health of people living with mental illness is being negatively affected. As you all know, people with severe mental illness typically die 15 to 20 years earlier than the general population. So it's particularly concerning that more than half of our respondents say that they are exercising less than usual, and around half told us they are eating less healthily. A fifth are drinking more, and 1 in 6 are smoking more. And there are specific concerns around how some psychiatric medications with physical side effects are now being managed. In line with wider healthcare trends, 36% of people say they have not booked or attended medical appointments due to worries about catching the virus, burdening the NHS, or because appointments have just not been available. And 16% said that they have found it difficult or impossible to get prescription medication that they rely on. There were some findings from the survey that surprised us in a positive way and can contain important lessons for a post-corona world. The number of those supported by benefits who say that their mental health has been made worse by the financial crisis was relatively low at 17%. So while some have been affected by delays in benefits being processed, others have commented that some of the changes have made their life easier. Face-to-face benefit reassessments are an issue that we have long raised as a problem and argued that people with mental illness should have the option to have a paper assessment instead. Now those face-to-face assessments have been paused, it seems to be having a positive effect. One person told us, "My benefit review has been put on pause for 3 months and as they couldn't conduct a face-to-face assessment, which is a massive relief." So in conclusion, I focused on what people with existing mental health problems have told us are the acute impacts of the first few months of the pandemic. There is much that needs to be done to address them and find the most effective ways of working in a completely changed world. It's clear that the need is increasing, and despite the incredible efforts by services, it's not yet being met. Finding those immediate solutions has to be our priority. It's crucial that in order to do that, we continue to listen to the lived experience of people using services. There's another immediate point to make. Ministers and scientific advisors have crucial decisions to make about which restrictions are eased at which points. They are qualified to do that in a way that we are absolutely not, but it is vital that mental health is an important part of those calculations. And it's reassuring that Chris Whitty has said that it will be, and we hope this data will help inform those decisions. We also hope that the challenges faced by people with mental health problems is routinely included in comms and initiatives to support the most vulnerable during the crisis. We were pleased to see that NHS England included specific messaging to this group in recent comms, encouraging people to continue to engage with services. But disappointed to see that a scheme initiated by DHSC that people with mental illness have been not.
Oh, I think we may have lost Danielle. Hi, sorry, I think we've lost Danielle. On top of losing me earlier in the call. I think Danielle was coming to the end of her remarks, but if we can get her back, then we'll go back to her. Apologies first of all for losing me while I was doing the introduction, and thank you to Jonathan from the Royal College of Psychiatrists for stepping into the breach and introducing Danielle from Rethink for her comments on the survey that Rethink have carried out. I was just about to run through the other speakers we've got for you today. So next we'll be going to Dr. Kate Lovett from the Royal College of Psychiatrists. We are very pleased to have with us Professor Sir Simon Wesley, who will be speaking about the likely mental health impacts of the social distancing measures and impact on frontline workers. You'll know obviously Sir Simon from King's College London and from leading the review into the Mental Health Act. And we have Conor Darcy from the Money and Mental Health Policy Institute, who is their head of research and policy, who'll be talking about the survey that they've carried out. So looking forward to hearing all of those speakers. And as I say, if we can get Danielle back, I'm hoping we will be able to get Danielle back and see her shortly. But in the meantime, perhaps we can go to Dr. Kate Lovett, who will be our next speaker, as I say, from the Royal College of Psychiatrists. Over to you, Kate.
Lovely. Well, thank you, Jeff, and thank you for that kind introduction. I'm Kate Lovett. I'm the Dean of the Royal College of Psychiatrists, so effectively responsible for training psychiatrists within the UK and developing continuing professional development. But today I am speaking in my capacity as consultant psychiatrist. A year ago, I was invited to speak at the APPG on mental health workforce at Portcullis House, and little did I imagine I would be invited back a year later to talk about my experiences and those of others working on the mental health front line in the midst of a global pandemic. So thank you for the invitation back. And last year, when I concluded my talk on mental health workforce, I concluded that workforce was the linchpin on which mental health reform success or failure would depend, and that the issue was urgent. In retrospect, urgency is all relative, and over the last 6 weeks, just maintaining essential services has become the pressing issue, and a workforce at threat of being depleted by up to 80% at any one time by the pandemic, more under the spotlight than ever. So this afternoon, I've been asked to describe my own experience as a consultant psychiatrist and those of other frontline clinicians since the impact of COVID-19 pandemic hit the UK. And the government policy of social distancing, the ban on mass gatherings, closures of school, and all but essential services, the so-called lockdown, which was introduced on the 23rd of March. The pandemic has affected every citizen in every aspect of their lives, both at work and their personal and family lives. And I think it's really important to remember that the health and social care workforce are no different in that respect. We too are often parents, partners and carers, juggling at the best of times, and how much more so currently. The week of the 8th of March will become indelibly marked in my memory for years to come. COVID-19 was starting to move closer to us all, and the initial handful of cases was starting to grow exponentially. That week, it had become evident that it was only a matter of time before all our efforts and attempts to contain the virus had failed. I was involved that week at the Royal College of Psychiatrists about our work, and involved in difficult decisions to cancel spring sittings of examinations and gatherings of over 100 people from the following week. We had a group of 200 school children due to join us that week for a careers event, which I just simply felt that having made the decision to cancel events from the following weeks, we couldn't go ahead with, but it was with much regret and sadness. And clinically at work, we're starting to get busy. We were starting to see increased anxiety amongst some patients and our colleagues. I think the most frightening words I heard that week were, well, it's business as usual until we hear otherwise. And sitting in a packed team meeting started to feel in our typical and far from ideal facilities like a death trap. I travelled to London to chair our last conference, and I'd managed to reduce my commitments at the college that week. I decided to go straight up and back to the capital, choosing a late train which I knew from experience would be quiet, except on that occasion it wasn't. It was packed with people travelling to the Cheltenham Festival. And suddenly the world seemed to be full of people coughing. I too had become vigilant to potential symptoms of COVID-19 and was anxious to avoid unnecessary risk to my own health. We were still trying to contain coronavirus, but on that day, the 12th of March, we moved into the delay phase. I chaired my conference that Friday, and the usual housekeeping rules now contained advice about hand washing. And meticulous though my attempts were to prevent contracting the virus, 5 days later I started to cough, leading me into self-isolation and quarantining my entire household for 14 days, including my asymptomatic husband, who is a much in demand anaesthetist. My symptoms felt rough, although in the scheme of things I had a very mild brush. And being off completely when my colleagues were struggling work was not an option. One of our locums had handed in their notice and left at the end of the previous week, leaving a caseload of 200 with no consultant or key worker, and I took it upon myself to make myself useful, starting to triage the caseload whilst self-isolating, grateful for decent IT and the ability to access clinical notes from home. I was tested 9 days into the illness by my local acute trust, which enabled my husband to get back to work. And although I tested negative, I remained convinced that I had COVID-19, with fairly typical symptoms being tested fairly late in the course of the illness, with a test that has a 20% false negative rate. I returned to base that week as we moved on the 23rd of March into lockdown.
Another one bites the dust.
Another one bites the dust. I'm sorry, I don't know if Kate can hear us, but we can't hear Kate.
I can hear you. Yes, can you hear me?
Oh, great. We lost you for a second, so it's great to have you back.
That's lovely. Now tell me where are we? So let me just go back a little bit because I think you may have missed something. So I was talking about one of our locums leaving and triaging notes.
So sorry, just a second, Kate. I don't think other people can hear you because we've not sent you live yet.
Okay, that's lovely.
Just to say I can hear Kate, it's Mary.
Okay, I think we've got Kate back live now. Are we going to go to Kate now?
I'm on.
I said you're going to have to bear with us for this first call. Have we got Kate live?
I'm on standby, waiting to go live. Jonathan or Mina to put the box on.
We seem to be struggling to get Kate to go live to the nation. I think some of us can hear her, so it's not that the lines are down. It's the technology we need to get a grip of, I think. Have we got Kate live yet?
I think because the video connection's weak, once it dropped off, we're unable to get her on.
Okay.
Oh, hang on.
Only the presenters can hear her, not people attending or watching.
Okay, people can hear Kate. So Kate, if you carry on speaking, we're good to go, even if you can't see you.
Yeah.
Okay, can you hear me? Yeah.
Yes, we can hear you.
Yeah.
So keep on speaking.
Fantastic. Okay, so I've just been talking, and sorry about the technical hitch.
But it's just us that can hear Kate.
No, everyone else can hear as well.
Oh, okay.
Excellent. Okay, so sorry about that, guys. So I've been talking about the impact of workforce. It was tight before we began all this, and one of our locums left, leaving a caseload of over 200 patients with no consultant or key worker. So I ended up triaging those patients, reviewing the caseload from home. I'm very grateful that where I work, I have good IT facilities and a system that means that I can access patient notes from home. I was tested 9 days into the illness by my acute trust, my local acute trust, which enabled my husband to get back to work. It wasn't my own employers that tested me, it was my husband's employers. And I tested negative, but I'm fairly convinced that I had COVID-19, typical symptoms, and I was tested fairly late in the course of the illness with a test that has a 20% false negative rate. And I returned to my base the following week as we moved into lockdown on the 23rd of March. And since then, I and all the staff have been working really flat out, quite often over weekends and late into evenings, to ensure that our services continue to function to reach the most vulnerable. But routine clinics have been cancelled, caseloads have been being triaged, and services have been majorly reconfigured to be able to withstand up to, the modelling suggested, up to 80% staff absence at any one rate, and to ensure that the most severely ill people still continue to receive vital medication and support. So over the time, we've been rapidly trained to use digital technology to conduct remote clinics and absorbed workload of a missing full-time consultant who's about to be joined at the end of this week as another locum leaves us and at the moment is unlikely to be replaced. Our old small teams have been suspended and we've joined forces across the city. I work in a deprived part of Plymouth. We've joined forces across the city into new larger teams delivering critical care and support functions. But we're now working with people who we may never have met, often remotely and often from home. And most appointments are now by video link, which is great for those who have access to the technology, but is beyond the reach of many of my patients, or by phone. And trying to conduct phone appointments, sometimes that's okay, and some people prefer that, but it's not at all straightforward when trying to assess the mental state of a person who's very distressed, whom you've never met, and particularly in parts of rural Devon where super fast broadband remains but a distant dream. On call, I've been to people's homes, the emergency department, the police station and place of safety suite. And when I'm on call, there's no middle grade. Consultants are first on call for acute work outside the inpatient wards. I'm resident on call in the hospital, and I found myself worrying, interestingly, not about lack of PPE when seeing patients, but about basic stuff like lack of washing up liquid in the doctor's residence, worrying about who might have been using the room a few hours before and how thoroughly it may or may not have been cleaned. I've really worried about my medical colleague, 50% of whom are from Black, Asian and minority ethnic backgrounds, in the midst of emerging statistics highlighting increased vulnerability to severe forms of coronavirus. I think we'd all be devastated to think that any of our colleagues had unnecessarily been put at risk because we have not yet understood ethnicity as a risk factor. 38% of our members at the Royal College of Psychiatrists are from BAME backgrounds, and the fear amongst my colleagues about this is very, very real. I've worried about colleagues with family overseas and, like many of us, supporting elderly and vulnerable relatives from afar and dealing with worrying illness amongst loved ones. So at the moment, clinical work is fairly busy with increased anxiety, poor sleep, relationships under strain during lockdown. Patients are really struggling with disruption to therapy, which Danielle's already described, but disruption to therapeutic relationships and, importantly, to routine, despite everyone's best efforts to find alternative ways to deliver it. Supplies of some medications have been interrupted and multiple queries relating to that, along with requests for sleeping tablet and medication for anxiety. And much of what we're seeing is a normal response of adjusting to extreme threat, and many of us will identify with not sleeping terribly well at the moment. For some folks, significant life events have already started happening, and loss of job, loss of businesses, loss of relationships starting to precipitate serious mental illness, including psychotic illnesses and mania. There'll be a lag effect for months and indeed probably years to come, with a ripple effect of the psychosocial impact of loss of loved ones and the economic fallout precipitating severe depressive episodes well into the future. We're yet to fully understand the neuropsychiatric consequences of the virus, but we already know that the virus has a neurotoxic effect, causing loss of smell, a loss of sense of smell, as well as other conditions like trigeminal neuralgia. And some early reports from China have suggested possible increase in psychosis. So the work was, is, and will be immense well into the future, and staff are already getting tired. And yet for those of us in frontline mental health service, there is no vaccine on the horizon that will end the health consequences, the mental health consequences of the pandemic. So that's my experience. What do the rest of my colleagues say? Well, recently, the Royal College of Psychiatrists undertook a survey of our members. We had a large number of responses indicating, I think, just how important this is to my psychiatry colleagues. In summary, the survey showed that people are worried about access to personal protective equipment, with 1 in 4 reporting they do not have access to recommended PPE. They're also worried about testing. Current guidance recommends any NHS worker or their family member should have access to testing, with only just over 50% reporting access for themselves and 30% access for their symptomatic family members. They're worried about referrals. So some subspecialty consultants report a drop-off of referrals, for example, in addictions and children's mental health. And as in physical health, there's a worry that many people may not be presenting in a timely way, and as a result, we may be seeing people presenting late in the future with more serious symptoms. And prognosis for any illness is always better when people are assessed and treated early. They talked about service changes. So like my service, many mental health services have changed their services rapidly, setting up 24-hour crisis helplines. And on the face of it, this is fantastic and has brought forward implementation timetables by 12 months. However, in any system where there's rapid implementation without time for full testing and consultation, teething problems are likely to be an issue. 51% of respondents told us they're working in reconfigured services with altered timetables as a result. And for many, that will have been a bit like starting a new job during this period, with different skills required, routine and new relationships. Only 14% of us told that they were currently able to work remotely using telepsychiatry. So I hope that that's been a helpful taste of just some of the issues we are grappling with just now. And in conclusion, I think it's fair to say that mental health services are definitely open for business, but it is currently within an extremely challenging landscape.
Great. That was really, really interesting, Kate. Thank you very much for that. We couldn't see you for most of it, but we could hear you. And it was a really interesting insight, I think, into the challenges on the front line. And the kind of anxiety that you have about your colleagues as well as patients, and some of the questions that lie ahead for us. So thanks very much for your contribution. Going to move on now to Professor Sir Simon Wesley from King's College London, President of the Royal Society of Medicine, of course, led the review into the Mental Health Act. Looking forward to hearing Sir Simon. Over to you.
Your mic's on mute, Sir Simon.
I think Sir Simon might need to unmute a microphone.
Yeah, done it. Yeah.
Right.
I've only done 20. I've only done 20 of these. You think I'd have got used to it by now, wouldn't you? God, I'm so looking forward to going back to proper meetings. Right. So let's see how far we get on before the technology kind of cracks up again. So let's start out that what we know already. We did a study of the impact of quarantine on mental health. We looked at all the previous research we could find in the last few weeks ago, and of the 25 studies, 24 showed there is a negative impact on mental health of quarantine, which is really no surprise. And that's not including things like boredom, frustration, anger, feeling miserable, irritated, and so on. So these things come at a cost. And that also showed there were certain groups who were more likely to be affected, clearly those with pre-existing mental health problems, no surprise there. Those who would lose their job, employment, very strong effect, no surprise there. Healthcare workers universally had higher rates of mental disorders, both during and after the episode, partly through fear of infection, giving it to others, and also increased mortality, which has been shown in most other epidemics. And then where the supplies ran out, unlikely to happen, I agree here, where it was accompanied by stigma of the group who were thought to be responsible for this. That goes right back into ancient history. Plagues and pandemics are always accompanied by some forms of civil disorder, and or often accompanied, I should say, but it's not in any way uncommon. And in particular, you have more lingering effects where the greater the degree of coercion that are being used, as opposed to altruistic appeals to, save your family, save the NHS, whatever. The greater the use of coercive powers, the greater the side effects, and where it was inequitable, where some groups seem to have done better than others, where it had not been fair, where in the end, when it was all over, it was clear some had benefited and some had lost, and there were more lingering effects. Now, the problem with all that literature is that actually that was almost easy, because most of those quarantine effects were quite small, the numbers involved were quite small, and the duration of quarantine was quite small. So to extrapolate to our current condition is very, very difficult indeed, because we have not been in this situation before. And when people say things like, oh, well, it's like being in the Blitz, we got through the war, we'll get through this, maybe, but that's not a very good illustration, to be honest, because even in the war, we should forget we didn't have to cope with social distancing. During the war, the cinemas, by and large, theatres, pubs, restaurants, etc., were open for nearly all of the war years at a cost of life when there were direct hits, but nevertheless, it was felt more important to foster intimacy, cohesion, and social support, which of course the whole point about social distancing, it does the exact opposite. So we are in uncharted territory. We can see some trends slightly from opinion polling and population studies, some of which are starting to report now. The first thing to say is compliance with what has been required has been little short of astonishing after a slow start where people were actually not very anxious about these issues. We know tending to regard this as like swine flu, the boy cried wolf before, but as those anxiety levels increased, so did compliance, and most of the behavioural change had happened before we were instructed to do so. So a truly remarkable social experiment, the like of which has never been seen before. What we can see already, though, is there's some segmentation going on. There's about the latest poll that we're going to publish in a couple of days will show that there are two large groups of people. People are pretty much getting on with this reasonably well. I'm sorry?
Is now joining.
Oh, sorry. Okay, the noise is off. I thought it was my dog for a moment, but it wasn't. So then there's another group, large group, another 45% of people who are definitely struggling with this, much higher rates of anxiety, much higher rates of depression and fear, and also very, very, very high compliance with the restrictions. And finally, there's a smallish group, but one would expect it to grow, I think, over time, who are, I would say, frustrated, angry, much lower rates of anxiety and depression, but much higher rates of non-compliance and also of drinking. So that's the way it is at the moment. As I say, large group complying pretty well and doing pretty well, large group anxious, depressed, etc., complying incredibly well, and many of them are also saying that if the restrictions were lifted, they still wouldn't go and go to work, go to restaurants, put their children in school, etc. So fear is very important in a segment of population, and are people who are not complying that well, a smaller number, but likely to rise. And then to finish, what about the healthcare workforce? Well, as I say, we can expect higher rates of disorder from the past. The exposure to the infection or the threat clearly comes at a cost, and also the belief, sometimes correctly, that you might be transmitting that back to others comes at a cost. The other cost that we outlined recently to bring to the NHS this concept from the military of moral injury where you are not able to do the job that you think you should be doing. You are not able to, the cases we originally described with people on peacekeeping operations who had to watch atrocities happening and could not stop them where normally they would have been able to. So in this situation, it'd be where you can't, you could have given the best care last year, you probably will next year, but at this moment in time, when a relative said, "Doctor, did you really do everything you could for this patient, for my loved patient?" Sometimes you might have to say, "We did the best we could, but it wasn't everything." And that also leads to, it's not a mental disorder, but it leads to anger and shame and guilt, and is one route in to mental disorders. We wondered if, and indeed thought that this could be quite an issue as the epidemic grew. I think it's fair to say that that's so far not seemed to be happening in the scale that we thought, possibly because actually in the end, at the last minute, as we always do, I suppose, the NHS has got its act together. Most of the concerns are indeed predictably from simple things, well, not so simple maybe, but direct physical measures. We had exactly the same from China. Concerns about equipment, PPE being way above all others, and of sleep and rest. And so when those are sorted out, we might see a different picture. And we also hear another narrative as well at the moment at the level of anecdote, but I suspect this will also be confirmed. For many are finding this a professionally very stimulating occasion. They are doing good, they are working hard, but they're being supported and supervised in a level they've never, sadly, never had that level of support and supervision, and they're starting to experience also the creation of tight social networks and esprit de corps and team spirit. So there's also positive things that many of those on the front line are reporting. How long that will last for, we don't know. Can we balance all these up? Well, it's difficult. You probably saw that report from the IPPR a couple of days ago that said that 50% of the healthcare workforce had mental health symptoms, and that 20% were thinking of leaving. This was reported by the press release as being a catastrophe, and that was the thing that the papers and the NHS picked up. I think we have to be careful with that kind of study. It's dealing in symptoms, not disorders, and there have been plenty of other studies that doctors, for example, in the junior doctors dispute, the first junior doctors dispute, I should say, which I was involved in, so it's that long ago, we had very similar rates as well, and the churn in the NHS, particularly in certain areas, has always been quite high. So I think that's probably an overestimate of disorder, and it's confusing symptoms of disorder. And so I think we have to be, I don't think we should think that we are as yet in a mental health catastrophe, but how the things will play out, we don't know. We're now running a study in 60,000 healthcare workers, health check, which should give us rather more accurate data. And the key thing here is what happens over time. Will we see an increased rate of mental health disorders, particularly PTSD and depression? Will we see an increase of this problem of moral injury? Will we also see an increase in neuropsychiatric issues? If this virus is neurotropic, as Kate has said, we should expect that, and an increase in fatigue syndromes. So at the moment, it's very difficult to say how this will pan out. There will be increases, but there will also be some people who will look back on this with some satisfaction of a period in their lives that they're proud of. There'll be others who may have very different emotions. But the key surely is to, first of all, to do everything they can to mitigate that, and second, to make sure that we do continue to track the health of the workforce for what I suspect will have to be quite a considerable time. Thanks very much. Stunning silence. I like the old days when people used to clap a bit.
Thank you, Sir Simon. That was really interesting. Thank you. I mean, inevitably more questions than answers, I think, raised, but it's really interesting to hear the questions that we need to be thinking about and the things we need to be doing in future. So that was a really kind of stimulating few minutes. I'm going to move on to Connor Darcy from the Money and Mental Health Policy Institute. Now, I understand, Connor, we can hear but not see. I'm getting a nod from my team to tell me that, but Connor is going to talk to us about the survey that Money and Mental Health have been carrying out. Over to you, Connor.
Thanks very much, and sorry for not being able to see me. You're not missing too much, don't worry. So Yes, Money and Mental Health Policy Institute. We're a charity. Our goal is to break the vicious cycle of money problems and mental health problems that so often go together. And at the heart of what we do is our research community. So this is a group of about 5,000 people who have personal experience either of a mental health problem or of supporting someone who does. So obviously, this is a group that we're really keen to find out how things are going for them over the past month or so and what they're worried about as they look to the future. So we've surveyed them. We surveyed them, I think, between the 20th and 30th of March. So that was the period when lockdown was happening and a lot of the first announcements, like the job retention scheme and the self-employment scheme, were being announced. We've also gone back to them with a more recent survey that's actually still in the field around income. So I'll give you some of the headline stats from that and a few quotes as well. I think kind of nicely summarize the situation. But I think the headlines would be that, as others have said, there's already been a widespread negative impact on people's mental health. And I think for a significant minority, we've already seen a negative financial impact as well, with others concerned that they're going to face the same in the coming months. It just hasn't quite hit them yet. And I think in terms of the support, either some fears around the adequacy of it, but mainly around the accessibility of it, I think. So I'll talk through some of those points. So on services, I think, again, definitely echoes what's been said earlier, particularly Danielle, where, again, the strongest fear that came through amongst the people that we surveyed was how they were going to access the support. So 86% of people said they were worried about not being able to access mental health services if they needed them during this period. And one person put it as, my anxiety has been through the roof. I've been having panic attacks. I'm still going out to the shops, but have developed a fear of contamination that makes it very anxiety inducing. I was having counselling, but that has been stopped, which is a blow, especially at a time when my mental health is suffering so badly. So I think it's really unfortunate double combination that, the current situation is making things so much worse, but then the support that would be there isn't there either in the at all or in the form that people would most rely on it. So the majority of the questions we asked were about kind of work, benefits, broader financial issues, how people are managing debts, and bill payments. So the main survey, that one at the end of March, we definitely saw some awareness of government schemes, and people, had been particularly worried, and things like the job retention scheme had allayed some of those concerns. But we definitely still saw people be very worried. 57% said they were worried or very worried about losing their job. And for some people, that was particularly linked to their mental health. So one person said, I've been told that I will lose my job. I've been on reasonable adjustments within my organisation while recovering from depression. The role I'm doing is to be discontinued because the company has decided it can no longer carry people. I'm devastated at the action of my employer of 15 years. So I think the concern there would be that actually people with mental health problems might be on the more, at the sharp end of this, who'd be facing some of the harshest impacts of this from how employers are deciding to manage this. So while there was people concerned about losing their jobs, I think it was more about then what would happen as the knock-on effect from that. So I think there was a straightforward one on just the hit to income that lots of people would face. Lots of people said they just wouldn't be able to get by on statutory sick pay given the relatively low level that it's set at. And similarly with universal credit, people were definitely concerned over just how well it would support them. So moving on to benefits more generally, as I said, the adequacy of things like universal credit was a concern, but it was also just the challenge of accessing that support in the first place. And this is a topic that we've done lots of research on over the years. It just really hammered home how difficult it is for people who are struggling with their mental health to be able to access benefits. Just the amount of information that's asked of you, the number of forms that need to be completed, kind of just general inaccessibility of the system when you're struggling. A lot of symptoms, common mental health conditions can lead to symptoms like, finding it hard to concentrate or problems with memory, all of which can make this really a struggle. And then when you add in the fact that lots of people are already facing additional worries with coronavirus, it just makes it that much harder. So I think it was sad but unsurprising then that 62% of people who we surveyed were worried about accessing benefits if they needed to. As well as the kind of the practical difficulties in that, there was a severe amount of phone phobia, which is it's really common amongst people with mental health problems. So just being able to try and get through on the phone to DWP is really tough, especially when, as we know, there's been extremely long wait times given the huge surge in demand. So that's a real challenge for people to be able to kind of stick it out with that and try and get the support that they need. And I think that was for new claimants, but we also heard from people who are already in the system who might be, say, trying to appeal something. So we had one respondent who had her personal independence forms. She would usually get support from Citizens Advice with that. That face-to-face service isn't available, so they weren't sure how they were going to be able to manage that situation. So that lack of support and the inaccessibility for lots of people, I think, was a really common one. So then moving on to what that actually means for the consequences of potentially having a lower income. While some people have savings, from a quick survey that we've done, the early results suggest that about half of our respondents said they wouldn't be able to make ends meet for more than a month. So that's missing payments, that sort of thing, cutting back on essentials. In terms of what's already happened, we've had 1 in 4 of those respondents say they'd already faced a drop in their income, and 1 in 4 of those had already missed a bill payment. So we can already start to see some really negative impacts coming through. So that's why I think the role of firms is so crucial in how this gets managed. There's been lots of really good stuff from a lot of companies to say, offering support, making it clear that there won't be negative circumstances or consequences in this period, which can be really important, especially for people with mental health problems who probably have a lot of anxiety around sort of communication. And it was definitely one of the concerns that was coming up. 56% said they were worried about creditors chasing them during this period. And things like just being at home more, having higher bills was a big worry. But I think what we have seen is some there was a story yesterday, I think, around some energy companies not communicating very well, debt collection starting. So I think how that gets handled is going to be really key. So there are just a few of the quick headlines. I think the recommendations that we had coming out of that were, for those worried about the drop in income, things like making statutory sick pay more generous and available to more lower paid workers would seem sensible and would help to ease some of the fall in income that some people are facing. For those moving on to benefits, obviously, it is really tough for DWP trying to cope with such an unprecedented surge in demand. But, going further on, being clear around the not applying conditionality during this period. And one pledge they've made that's really welcome is that they'll identify vulnerable claimants and offer them more support. So that could be really helpful for people who struggle with accessing benefits. But we haven't seen much detail on that, so figuring out exactly what they're going to do on that, particularly for those who struggle with using the phone, I think is going to be really crucial in the coming months. And as I said, firms also have a big role to play. Last week we published some customer support standards that firms can quickly put in place to help reassure customers. It's would reassure all their customers, but particularly those with mental health problems. So it's things like proactively offering forbearance, making sure people aren't disconnected from any of the services. And generally offering different ways that people can get in touch if they have problems to raise. So I think that's it from me.
That's great. Thank you very much, Connor. I really appreciate that perspective from your research. We're going to move on to questions fairly quickly. And with some slight trepidation, I'm going to try and call in a couple of our members of the House of Lords who are on the call today, who are members of the All-Party Parliamentary Group on Mental Health, who are on the line. Hopefully we'll be able to ask questions of our panellists. First of all, I think we've got Baroness Tyler, I hope, is on the line. I'm hoping that Mina can connect Baroness Tyler. Can you hear us?
Can you hear me?
Yes, we can hear you. Thank you.
Excellent. Well, thank you so much. I thought they were really excellent presentations. The point I wanted to pick up, and several of the presenters did refer to it, was the impact of people of both social distancing and having to isolate, of people who are living by themselves. I'm particularly conscious of people who are perhaps over 70, of whom I think about 3 million actually 70 plus are not internet users. And the number of people in that age group who are lonely under normal circumstances. My sense is that when the social distancing guidelines were introduced, no one really paid very much attention to what it would be like to people who are living by themselves, in some cases even very recently bereaved, with perhaps a sort of a close family member who has died of the COVID. And other family members aren't allowed to come and sort of comfort them and be with them. And I suppose I just feel really concerned about the mental health consequences of that, and we're really interested in any sort of ideas or thoughts you've got about how that could be tackled.
Great. Thank you very much for that question from Baroness Tyler. I'm going to move on if we can. Thanks very much for that question. I'm going to move on if we can to Baroness Watkins, who I think is also on the line and would like to ask a question. Then we'll go over to our panelists.
Thank you very much. And again, thank you for the really excellent presentations. King's College have just done a survey in nursing and midwifery, which from 2,600 members of the workforce replied that 74% feel their personal health is at risk at the moment, and a third report feeling severe or extremely severe depression, anxiety or stress. And I really wonder how we can influence employers, not only in the NHS, but in social care, nursing homes, residential schools that employ nurses. I've been talking to some people working in a home for people or children with severe autism. And I think people need supportive interventions now, and probably for at least another year, to meet their psychological needs and provide psychologically safe workplaces where concerns can be discussed openly. We know, for example, that people have been encouraged not to talk about a lack of PPE, or not to talk about how they feel when a whole group of residents dies, that their responsibility is to the people they care for and their families. And so I've got some real concerns that the government kind of see all this as the next stage rather than something we need to start dealing with pretty quickly.
Okay. Thank you for that question as well. If any of the panelists would like to have a shot, we've got Baroness Tyler wondering about the long-term impact on people living by themselves, particularly vulnerable older people. And then the question about how we can get employers to give more long-term support and safe workplaces. If anybody would like to, Sir Simon.
Yeah, two things. I mean, first of all, we haven't yet, as far as I know, got any evidence on the impact on the elderly from this country. But I mean, not surprisingly, there is already stuff appearing from Spain and Italy. Not surprisingly, it's pretty bad. And the combination of loneliness, which is not the same as social isolation, as you know, and loneliness together seems to be mutually, what's the word I'm thinking, the two together are worse, is what I'm saying. It would be astonishing if we don't find the same in the UK. I really want, and I'm sure, Claire, you're not surprised to hear that at all. But to Baroness Watkins, I mean, I'm surprised that what you've just said. I'm not surprised that you said it, but I'm disappointed that we're hearing such stories, because certainly the general message that has been pushed from all sides on how do you support the workforce during this very testing time is very much not to tell people not to talk about these things. It's to try and reinforce the concepts of leadership and being in a team, and to have, you know, whatever you wish to call them, cafes, washdowns, whatever, all the different ways in which at the end of a shift or whatever, people can come together and express their concerns, particularly about when they've been put in very difficult and intolerable situations. And the whole point is that this is not an individual issue, this is a team issue, and that it is also a question for, you know, your immediate supervisor to hold those fears with you. And if they just simply block you from talking about them, that's definitely not what should be happening. That's very poor practice, I would say. People like us, mental health professionals, we're not, there's no way we can counsel our way out of this problem. We are there to help people the people who to devise the policies, so leading the groups, etc., leading the teams, etc., and then to see the occasional people who have gone beyond a normal emotional reaction that everyone feel in this situation to actually having a frank mental disorder. So we're a kind of second or third line of defence. And indeed, if we get into the front line of defence, we can sometimes make things worse. And we know from China that that's not what people want most of the time.
Thank you. Thanks, Sir Simon. I don't know if any of the other panelists would like to just add anything to that comment.
So I completely agree with that, but I think what this has shown to me is how woefully ill-prepared we have been within our systems going into the crisis. And whilst leadership is absolutely fundamental, being a good boss is the key to this, and how workforce feel. We weren't there before we went into the crisis, and around 50% of sort of managers, line managers, are band 7 or below. So we're talking about often fairly inexperienced leaders who certainly won't have been supporting teams and so on through anything like this ever in their careers, and they will need a lot of support to get through. I think my real worries are not about the health service. I think it's pretty good from what I can see, but my worry is about leaderships in the places where leadership training really isn't a thing. In the some of the care homes and so on, and institutions that are harder to influence. And I think what this has also shown, going back to Claire's point about loneliness and staying connected, is about the divide, the digital divide that this has shown up. And it's not just elderly people. I know many, we all, there's lots of elderly people who use technology extremely effectively, but but there are pockets that just haven't been able to access it prior to the crisis. But I see it within my age group of adults of working age. There are stark differences between those who have and already using technology quite comfortably and those who don't.
Thank you, Kate. Any other contributions? If not, I'll move on to a couple of other questions we've got. I've got a question from Patrick Vernon, and he asks, what is the panel's view on equality issues, on what actions we should take to support the BAME population who are disproportionately affected both as frontline staff and in their community. And perhaps just while we're on that general topic, we did have a question asked about Danielle's and Kate's surveys, just whether there's any more information that you could give us about the respondents to those surveys. So anything particular on gender, ethnicity, any patterns there. And again, any patterns in terms of who isn't contacting services in terms of ethnicity. So particularly if there are issues where BAME people are not contacting services. So I think perhaps it's a question for if anybody wants to talk about that particular general set of issues, but perhaps Danielle and Kate may be able to give us an insight into some of their respondents. Any takers? Danielle?
I have to confess I haven't actually got the demographic breakdown in front of me, for which I apologise. However, what I can tell you is that the vast majority were women, the vast majority were adults, and the vast majority were white British as well. None of which massively surprised us. When we have in the past tried to, we have always found BAME groups hard to reach. Despite sort of trying, you know, sort of despite our best efforts. I think it is, you know, I think you're absolutely right to raise the point. It is extremely concerning, and I think it's in sort of thinking about inequalities from a widest perspective. One thing we're not another group that we're just not hearing from at all, which I am extremely concerned about, is inpatients at the moment. Virtually everything we're hearing about the impact on services and the impact on service users is from clinicians, and whilst they are extremely valuable perspectives, we absolutely need to hear from those people who are in services, and particularly in sort of linking back to the minority ethnic point, hearing from people who are detained under the Mental Health Act at the moment, of which we know there are a disproportionate amount from BAME backgrounds, and that is something that I'm really concerned about, and that I think we need to make concerted efforts to hear from directly.
Great, thank you. I don't think we can hear Kate right now. I think we've lost Kate again temporarily. So if none of the other panelists want to say anything on that set of questions, we've got a couple of different questions. Firstly, there was a reference earlier on, I think from Kate actually, to, and Sir Simon took it up as well, on the neuropsychiatric effects of the virus long term. Now, I appreciate this is something that we're not going to understand now. I wonder whether we have any idea as to how long it might take us to understand those effects, how long it's going to be before we really get a grip on what the long-term effects of the virus might be. That might be something that Sir Simon may have a view on. And I suppose the other question is what we can learn from other countries. Simon was referring to Spain and Italy. Is there anything we can learn at this stage, or is that again a more long-term?
Okay, well, firstly, on the longer-term neuropsychiatric, I mean, it's clear that there seems to be a much higher level of confusional states arising even in ITU, where these are quite common, but they seem to be even commoner in the current situation. And there's some, again, data from Italy suggesting that the virus is neurotropic, as we say, and of course the fact that one of the characteristic symptoms is losing smell and taste suggests that it is. Now, again, some of those symptoms have always gone with severe viral infections anyway, even ones that don't get into the brain. Epstein-Barr glandular fever, for example, also has neuropsychiatric complications, but it doesn't, as far as we know, get into the brain. So it's a bit early to say. And if we look historically, if we're thinking of, you know, really serious outcomes, such as happened in 1918-19, you wouldn't see those for at least 1, 2, 3 years. So again, a reason for setting up now the kind of long-term studies, not the short, fast surveys, but the longer term studies, population studies, is so necessary.
I think we've heard back from the audience that the chat is stuck and Danielle is playing on a loop.
Oh dear.
Because we are having a bit of an issue, both Jonathan and I, to send people live. So let's just...
Do we know anybody who can give us any enlightenment as to how we can solve the problem?
I think if so Jonathan and I will stay on the chat, but if other people are willing to leave the chat and come back on, we can resume it in really quickly. So
you want all of us to do that? Mina?
No, anybody who wants to speak. I think you shouldn't, because finally we've got a proper connection with you. But if Sir Simon and Danielle maybe can log out and log back in, or leave the chat and then join again.
Do you mean mute or leave?
Leave.
And so how will we know when it stopped looping on the feed?
was going so well. Yeah, it's still on a loop. That's what the comments are saying. It's when Danielle started.
Okay. I don't really know what to suggest. I mean, other than switching it up and starting it up again, which is usually the thing that works.
Yes.
I've got a great view of Claire. Can Claire not hear us? Claire?
Yes, I can hear you. I came out of the chat just in case that helped, but I can hear you, certainly.
I can see you and hear you, Claire. This is paradise.
Brilliant.
Good. How are you?
I'm fine, thank you.
So I think we missed quite a bit there. So I'm not sure where we got to, but I think the answer to the question, the answer to the question on will we know whether this is going to be like 1919 again, will be that took till about 1922, so it won't be 2 or 3 years, and that's why we do need big population studies also to answer the BME questions, because we know these quick and fairly dirty surveys always miss the groups that are most affected. This is not me just talking up good research. Well, yes, it is me talking up good research, because that's what we need. Otherwise, all we'll always get is very biased surveys with, first of all, overestimating the levels of symptoms and missing those who have clearly been most affected, which in answer to Patrick's question, and I'm sure this is the Patrick who worked with me on the review, lovely to hear from you, you know very well that BME people are being more affected and will be, but they won't be picked up on these quick, short surveys we're hearing, and that won't help very much.
I think, Simon, we probably didn't hear your original answer.
Okay.
I don't think we
didn't hear that.
Answer to the question on neuropsychiatric effects or the comment you just made, I think.
Okay.
I'm looking for
it. Nobody else
whether we did. Sorry.
Kate's smiling, so she can hear me. Come and join the RSM podcast. We've learned how to do this.
I've just had a text to say it's completely stuck on a loop of Danielle speaking, so.
Oh, well.
Oh, it's moved on. Apparently it's just moved on now, so I think we're live again.
I think if you restart from your point about good science about BAME groups mostly being disproportionately effective, I think that's when it went live.
Okay, well, I mean, this is a plea to you lot, this is why you need now to insist on strong, good research on population level. Number one, that's the way how we'll pick up these long-term effects. Most of these surveys that we're doing at the moment that we've already heard about are perfectly okay, but they're anonymous, you can't follow people up, and they're very biased towards certain groups, as Danielle herself said, and they miss the group most vulnerable, which is already becoming clear, is BME. That's Patrick's point, and to say hi to Patrick Vernon, nice to hear from you again. But you need much stronger, more powerful survey designs that are random population samples if you're going to see the true picture here. Otherwise, you'll both overestimate the degree of worry, but underestimate the actual degree of morbidity, disease, and outcome.
Great. And perhaps, Simon, if you don't mind, just recapping the question of how long it might be before we can understand the neuropsychiatric effects of the virus. Okay, I don't think we've got any of that either, I'm afraid.
Okay, this is the 4th time now. I'm getting better at it, if you're not. But it takes time. It's clear that this virus has neurotropic properties, as we call it, but others have as well. And also some infections, such as Epstein-Barr, create long-term post-infectious fatigue syndromes and don't get into the brain. But if this one does, then, and there's certain evidence that it might be the higher rate of confusional states, this characteristic anosmia and lack of taste, lack of smell, that suggest that as well, then the risks are, as I say, more immediate acute neuropsychiatric problems and unfortunately more mortality, which we're seeing. Second, a greater risk of long-term fatigue syndromes. And third, an unlikely possibility, but we have to say it's happened before, of an increase in dementia and Parkinson's has happened in 1919 and 20, and we would expect that not to be visible for at least, well, it took 2 to 3 years. And that's again why you've got to lay down sound research foundations now, because this is not, when this is over, it's not over.
That's really interesting, thank you. Okay, I'm going to move us on to a slightly different topic, I think. We had a couple of questions from Meg Stapleton at the charity Independent Age. One is about, I think, quite an interesting question about the restrictions on funerals and bereavement support. And the fact that it's kind of changing the nature of bereavement. The question is whether the panelists, how do the panelists foresee this affecting people's grief journey in the coming months and years, I guess. So maybe if I can put that question.
Badly. I mean, what more do you want to say? Obviously badly, and everybody knows that. Yeah. I mean, I don't know what else one can say, really. It's clearly, it does affect the grief process. There's a lot of evidence that will lead to more complicated grieving and more atypical grieving. Kate, do you want to say more on that?
Yeah, no, I agree with that. I guess we have, you know, culturally ingrained patterns of how we behave in the face of loss, and to have a double whammy of losing a loved one and then be losing what we know and has you know, is a fundamental pattern of behaviour that we've observed and taken part in, you know, throughout our lives, is going to be very, very hard for people. You know, not saying goodbye to people will be very tough, and not seeing bodies of people who've died after death, and not being able to celebrate their lives through large funerals, you know, and social gatherings. Absolutely. Yeah. So we're anticipating, you know, the fallout of this, I think, for a long time to come.
And we just got, and just to make the point, you know, my colleagues in epidemiology doing all this modelling and things like that. These are things you can't model. You can't model those kind of effects, but they're profound and long-lasting. And I worry that we're not taking sufficient account of these psychosocial, social disruptions that will last for years as we start to assess the risks and benefits of our current, of what we're doing. And, you know, we've got to start thinking about those issues. And you know, this is not a thing. This is not a thing that you can ask epidemiologists and modelers and people like us to give you figures on. You've got to use your own judgments as politicians as to how much hurt and pain can we take and for how long. And you're not going to get advice from people like us on that. Mm.
Okay.
Yeah. You've got to step up to the plate.
Yeah, no, that's absolutely, that's an important point and well made, I think. And a number of the questions we've had through are kind of asking for advice on how do we deal with a particular issue. And I think you've illustrated really that this is uncharted territory for many of us, and you know, there are no easy answers to any of these questions, I think. Another question that has been sent through from Baroness Lister was just wondering about the panel's views on the mental health of people in cramped accommodation, particularly marginalised groups, people living in poverty, asylum seekers. I think I may get the same kind of answer. It's going to be bad. It's going to be difficult. Is there any? I mean, that's. Go on then.
Well, all the evidence of history says exactly that. And the marginalised groups are the ones who have the worst outcomes because they're often stigmatised when this is over. Now, the only thing you might say in the current situation is because at the moment everyone is in the same boat. It seems less likely that there will be, you know, the kind of awful scenarios. The whole anti-Irish feeling in Britain began in 1848 after the cholera riots in Liverpool, which were blamed on the Irish, and it lasted for 100 years. At least 100 years. Now, that might not happen this time because I don't think you can single out a particular group and say they're the ones that transmitted this. But that is always a risk in pandemics, particularly when it's over. And and it affects, we know it affects the poorer. They're the ones, it's okay for me, I've got a job, and I also live in a house with 2 bathrooms, so when my wife got ill, we could actually carry out all the various social distancing. Not it made much good anyway, but we did. But you know, you don't need people like us to tell you that. You really don't.
Okay.
And the longer it goes on for, the worse it gets, and you don't need us to tell you that either. Yeah,
sure. Okay. I think we've lost a number of our speakers due to technical problems. We've got Sir Simon, who's
I can't give the same answers again.
It's as fascinating as ever. No, it's absolutely great that you've been here. And we've got Baroness Tyler. I don't know if Baroness Tyler had any other questions or comments that she wanted to make.
Just one thing, it was just picking up something that Simon said, which was really interesting earlier on, about how this is actually about it being so unknown, because it's actually very different to the sort of blitz experience,
Lovett
because everyone was
now joining,
you know, had a sense of being in that together and bonding and being together in pubs and, you know, whatever. And this is sort of so different to that because of the social distancing. Yes. And I just sort of think that there is a strong sense of, you know, we've all said it, we're in uncharted territory here. And I just think that more and more attention is going to need to be paid to this whole sort of social distancing thing the longer it goes on, because it's just not tenable, is it, that for 12 to 18 months, even families, particularly with older family members, can't even see each other.
I agree completely.
Kate,
and tell you
Lovett is now exiting.
There is one almost amusing in a way, is that this time last year, Claire, you and lots of others were talking about the malign effects of social media on the mental health of children, etc., etc. I was always slightly skeptical and thought it was a bit of a zero-sum game. And now all of a sudden, social media is our saviour, and everyone's saying how wonderful it is and keeps us all together. And so that's an interesting change that's happened. I think it was always blaming the medium for the message. So that's the first point. And the second point, I can't remember what my second point was now. Okay, what was your second question? What was it?
It was about
how long
we could sustain this, not even allowing family members to see each other.
Yes, obviously I agree with you, and then I did mention analogies with the Blitz aren't quite accurate because they didn't social distance, and we just literally don't know, except that our social networks are the strongest predictor of good mental health, is having good social networks, and maybe social media and all these various things are a good replacement for them. I don't know. I'll tell you one thing, we're going to find out.
I wonder if that's an appropriate point to leave it on. We are going to find out. It's going to be a difficult process to get through this, and then we have a lot of long-term learning to get through. I just want to say thank you, particularly to Sir Simon, for being here throughout the call and being as fascinating as ever.
I think it's just the four of us now, isn't it?
To our other speakers as well, Danielle and Kate and Connor, and to the people who've set up the call. Apologies for the technical difficulties. We are, the point has been made a number of times that we're in uncharted territory. And this kind of virtual APPG meeting is also uncharted territory for this group, but we've learned a lot, I think, from this process today. I've no doubt that our next meeting will be slightly smoother technically, but I've certainly found it a really interesting conversation, really interesting presentations from all our contributors. So thank you very much to those people. Thank you for the large number of people who've joined us online. It's actually a much bigger attendance than we would normally get for a physical all-party group meeting. So we're really grateful to all of our speakers for contributing and making that meeting happen. Thank you once again. I think we're going to wrap it up there. Thank you.
Okay.
Thank you.
Thanks. Bye-bye.
Bye, Claire. Good to see you.